Welcome to today's ASCO University podcast. I'm Tim Price. I'm a medical oncologist from Adelaide, Australia. Today's podcast is based on the recently published guidelines around HER2 testing and clinical decision-making in gastroesophageal adenocarcinoma. The background is that, of course, gastroesophageal adenocarcinoma is estimated to represent 43,000 plus cancer cases in the United States in 2016. Therapies for advanced gastroesophageal cancer are somewhat limited beyond chemotherapy, and cure is rare. There is, however, the HER2 positive subgroup where treatment with trastuzumab and chemotherapy has seen improvements in survival outcomes. But because of the different definitions between breast cancer and gastric cancer, a separate guideline was felt required. These guidelines were overseen by a multidisciplinary international panel with experience in this cancer. The aims were twofold. Firstly, what is the optimal testing algorithm for the assessment of HER2 status, and what strategies can ensure optimal performance, interpretation and reporting of established assays? These recommendations, of course, as alluded to, are based on the TOGA trial, which confirmed a survival benefit to the anti-HER2 monoclonal antibody trastuzumab when combined with cisplatin and fluoropyrimidine chemotherapy compared to the chemotherapy arm alone. The overall survival was improved from 11.1 months to 13.8 months, representing a 26% reduction in risk of death, with a hazard ratio therefore of 0.74. There were, however, broad definition of HER2 within the TOGA study, and there were some patients with immunohistochemistry 0 or 1+, but ISH positive, who were included, but it was felt that the clinical benefit here is minimal, and this led to the definition of HER2 positive, which I'll come to later. One other point I wanted to make was that clinicians should note that patients were screened for and excluded if there was significant cardiac risk factors within the study, and this led to a low cardiotoxicity risk and no difference between the treatment groups, remembering that in breast cancer there was of course evidence for cardiac toxicity with trastuzumab. Also, as HER2 does not appear to be prognostic, HER2 testing is not recommended unless therapy is being considered, and there is of course no current evidence for anti-HER2 therapy in the resectable population. Another couple of points to note, of course, is that most analyses have found that the HER2 positive rate is around 20%, so it's 1 in 5 of our patients. HER2 positivity is also common in the intestinal and well to moderately differentiated pathology, and also for those patients with a gastroesophageal junctional primary. There is, of course, no evidence to repeat HER2 on progression, given the lack of evidence for continuing trastuzumab beyond progression or switching to an alternate anti-HER2 agent in second line. So some of the key recommendations: patients with advanced gastroesophageal adenocarcinoma who are potential candidates for HER2 targeted therapy should have their HER2 testing on their tumour tissue. Some patients, of course, may not be suitable for systemic therapy, and thus testing for HER2 may not be required. Treating clinicians or pathologists should request HER2 on the primary resection or biopsies from the primary or metastases. If not available, however, a fine needle aspirate derived cell block is an alternative. Testing for HER2 should start with immunohistochemistry, and ISH testing is only performed if indicated. One of the key pathologist's recommendations is that patients are defined as HER2 positive if they are immunohistochemistry 3+ or immunohistochemistry 2+ and ISH positive, with ISH only performed in the 2+ group. Patients should be offered combination chemotherapy and HER2 targeted therapy as initial treatment where there is a positive HER2 result. It is worth noting that the committee have not defined the actual chemotherapy schedule, and there are a number of options available, but these, of course, were based on smaller phase 2 trials. In some cases, commencing first-line chemotherapy awaiting the HER2 result may be appropriate to avoid the risk of progression, and then subsequently anti-HER2 therapy is added to subsequent cycles if a positive result is found. In terms of the pathologist's recommendations, one comment was made around turnaround times, and these are important. It's suggested that 90% of reports are available within 10 days, and where testing is not performed on site, specimens should be sent to a referral centre within 3 days, 90% of the time. The other key pathologist recommendations are as follows: antibodies and probes should be specified and validation of assays should be undertaken. The Rushhoff-Hoffman method for scoring immunohistochemistry and ISH should be used. The tissue block selected should be from the area with the lowest grade morphology, and this is based on the TOGA results comparing the intestinal versus diffuse groups. The CAP template should be used to report HER2 results. Where ISH is required, the area of strongest intensity of HER2 should be used. The HER2 testing should be incorporated into the laboratory's overall quality improvement programs, and currently there is no evidence for or against genomic testing for gastroesophageal adenocarcinoma. So just to conclude, the guidelines reinforce the clinical benefits in terms of survival and other endpoints for HER2 positive gastroesophageal adenocarcinoma, and they give an important background to the appropriate testing of HER2, which is useful for both the treating physician and reporting pathologist.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.